I get to today's lecture topic. Did you guys sign up for the right lecture? Oh, wait, I can pull this down. I don't see you guys with masks. All right. How I got to this one was because of a new medication that's out. And as I reviewed the new medication, I saw that it had an impact on quality of life and mortality with heart failure. And so, because heart failure is so common, I thought it would be a good topic to talk about in case anybody in here has it or anybody in here knows somebody that has it, because this information is pretty good, okay? So what I always like to do is give you some data about what we're talking about so that everybody understands the situation we're in the middle of. And it's interesting, I've been doing this for 34 years. It used to be most research was related to keeping the patient well and helping the patient stay well. And now what I find that kind of gets my attention is a lot of the data speaks to the fact that it will keep you out of the hospital and get you out of the hospital faster. And that caught my attention because in all the years that I've practiced, I never paid attention to the hospital the way they pay attention to it now. We use the hospital to diagnose and treat people, and most times, say 25 years ago, the length of stay that you stayed at the hospital was irrelevant. But now, as you guys may or may not know, the time you spend in the hospital is very relevant. In order for you to get post-hospital benefits, depending upon what your insurance is, and of course, this is different because you guys get the whole package, but just in general population, you have to be in the hospital 2 midnights. And I just thought that was a curious way to write the rule, but that's how it works. So if you're in the hospital for 2 midnights, then your Medicare benefits for post-hospital care kick in. But you have to be admitted. So for those of you in the room, what I will repeat, because I've had it spoken to me today with a couple patients, they weren't admitted. They were made observation. So it's up to you to make sure that if you go to the hospital, and obviously we hope no one does, that you know before you leave the emergency room to go to the floor whether you're being admitted or made observation. What do you want? Admitted. So if they say you're going to be observed, what do you say? Send me home. I'm serious. That's what you say. Send me home. And they say, we can't send you home. You're sick. Well, then admit me. And they'll say, well, no, we're going to make you observation. And don't ever be rude with them because that doesn't get you anywhere. But what you say is, please call my Medicare representative, the phone numbers on the back of my insurance card. And 100% of the time you will be admitted. So everybody follow me. Please take that away from today, guys, because I've had so many patients you get flustered. You go to the emergency room, all you're doing is looking at the ceiling and seeing faces pop in front of you, and everybody's telling you stuff you don't understand, and the next thing you know, someone's taking you to a room. You have to pay attention. You have to make sure you ask, am I being admitted? And when they say, oh, yes, we're taking you to a room, am I being observed or admitted? Please push that because it makes a big difference. If they make you observation, then it's like outpatient. What does that mean? You get stuck with co-pays and deductibles. If you get admitted, it's under Part A, and your Part A pays for all that stuff. Does everybody understand? That's very important. Okay, enough of that part. So what we're going to talk about is congestive heart failure. Nice heart, huh? Right side, left side. There's a top and the bottom. The top is called the atria. The bottom is called the ventricle. Okay? The right side of the heart, when the ventricle pumps, it sends blood to the lungs. The left side of the heart sends blood through the aorta to the rest of the body. Okay, does everybody understand that concept? Very important to recognize. The heart squeezes, that's called systole, and it relaxes, called diastole. Okay, everybody understand that concept? So you have to recognize it's going to squeeze, send all that blood out. But what happens when it's filling up again? As it begins to relax, all the blood flows back into the heart. Does everybody understand that concept? And it all comes, sorry about that, it all comes to the right ventricle. Right aorta. And this is what's called the superior vena cava and the inferior vena cava. So all the blood will make, so everybody understands, so down from your feet. All the blood makes its way back through the superior vena cava at the top, inferior vena cava at bottom to the right atrium. And this is the most important part to understand for congestive heart failure. If you haven't heard this term, you will know it by the end of today. BNP stands for B natriuretic peptide. What is that? It's a protein. What does that protein do? That protein is an indication of heart failure. Does everybody follow me? So when you go to the hospital, they're going to get some labs on you, and one of them is the BNP. And I have seen people get treated just from the BNP. If that BNP is elevated, then chances are you're in a congestive state. Does everybody understand the concept? You need to understand these basics as we go through everything, so the quality of life and the mortality piece you'll understand better. So everybody understands the heart's going to squeeze and relax. I might as well give you the other part of this. There's a valve here and a valve here. This is called the tricuspid valve, and this is called the mitral valve. And then there's a valve as the fluid's coming out of the left ventricle. This is called the aortic valve. And remember, this one's going to the lungs, called the pulmonic valve. Why is that important? Okay. We'll put CHF, congestive heart failure. And we go over what is congestive heart failure. Congestive heart failure is when the beating heart is unable to pass all the blood to the rest of the organs, okay? And so what happens is there may be a squeeze, the blood is supposed to be sent out, but for whatever reason, there's a backflow of that blood, and we'll go through those reasons. But everybody understands the concept. When the heart squeezes, all the blood is going out. The right side comes to the lungs, the left side through the aorta goes to the whole body. Does everybody understand that? Okay, so what we have now, I'm going to go through causes. Over here, always congenital. Over here, structural. What does that mean? What are the structures in the heart? We talked about the valves, and we talked about the muscles, okay? Structurally, you can get trouble with the valves. What happens? When the heart squeezes and the blood goes out of the ventricle, the valve here opens up so the blood from the atrium can fill the ventricles. Everybody understand that concept? So if there's a problem with that valve, what can the problem be? Too tight, okay, valvular stenosis, or not functioning, so it's what's called insufficient. So instead of this valve stopping the blood from going down to the ventricle, the blood keeps moving forward. Does everybody understand the concept? So the congestion can come from the valve not functioning or being too tight. So that's what you want to understand about structural. The other thing that's important is these valves all have little muscles. They're called chordae tendineae. And so what can happen sometimes is we can get infiltrating disease in there. I'm trying to think of who's the guy. Mayor. He was a mayor of Pittsburgh. He had an infiltrating process in the heart itself. I can't think of his name. Sorry, guy. There you go, Caligiuri. Thanks, guys. You read my mind. Anyhow, what happens is it's an abnormal protein that infiltrates these little wee muscles. And so that causes a restrictive heart disease, meaning that the heart's not able to relax. Does everybody understand that concept? So it squeezes, lets all the blood out. If it can't relax, then there's a problem with the flow of fluid coming back into the heart. So conceptually, understand structure. The other thing with structure, hypertension can lead to LVH. What's LVH? Remember we said right and left. LV stands for left ventricle, and H stands for hypertrophy. What does that mean? The bodybuilder lifts, the bicep becomes hypertrophy. What does that mean? Gets larger. So what happens when the heart gets larger from hypertrophy? And what's it come from? High blood pressure. The function changes. Instead of it being a nice squeeze and a nice relaxation, you can end up with abnormalities when it gets enlarged. So everybody understands. Those are the big structural ones we talk about. What else causes problems? Coronary artery disease. What is that? Those are the arteries that fit over the heart, and if they get blocked up, it doesn't provide enough blood to the heart muscle. And so what happens is the heart muscle becomes impaired. How do we measure that impairment? It's called ejection fraction. What's normal? 65 to 70. When do you run into a problem? Less than 40? Definitely when you get less than 30. And we'll talk about that problem. So coronary artery disease stops the flow of blood to the heart muscle, and if the heart muscle doesn't get the blood it needs, it becomes less than its normal function. And that less than the normal function affects the ejection fraction, so when the heart squeezes, the amount of blood going out of it is less than normal. Does everybody understand that concept? Okay, these are real important things. That's why I'm beating it up to make sure everybody understands. So we all understand that? Perfect. Take a break. You just did really good. All right, now, congestive heart failure, diagnosis, treatment, quality of life, and mortality. How do we make the diagnosis? Everybody here should have had a chest x-ray in their life, right? They tell you put your arms up, lean over the machine, and they tell you to hold your breath. So take a deep breath, hold it, you hear the machine make some noise. That's getting us an x-ray. What does the x-ray show us? We'll draw the whole body. I'm such a great drawer. Well, at least I used to be. Okay, so this is what we're looking at in the chest. Right side and left side. Heart sits in the middle. We're looking at the diaphragms, and we're looking at markings coming off of the heart. So with the heart in the center, if there's fluid, you see what we call curly B lines, or you'll see some lines in here of fluid. That's what we call increased vascularity. So that's showing us that in the lungs, some fluid is building up. Is that definitive congestive heart failure? Not really. It's just showing that the heart's not clearing the fluid like we want. So it could be a pre-congestive heart failure, but it's a test we always do is a chest x-ray. We just talked about the BNP. So we get the BNP, we see what that number is. We also get a cardiogram. What does the EKG show? Hopefully everybody in here has one. They put the leads on your chest, on your arms, and on your leg, and it shows us the electrical activity through the heart muscle. So what happens is if the heart muscle has abnormalities, we can find that out by the electric signal. What are we talking about? Remember we talked about the enlarged left ventricle. So left ventricular hypertrophy, it does show up on the EKG. What else are we looking for? The rhythm. I'm sure everybody in here has heard of atrial fibrillation. That's very common with congestive heart failure. What else are we looking at on there? Ischemia. So we see changes. Instead of a nice P wave and a QRS and a T wave, you'll see changes in the QRS. So you might get elevation of the QRS wave. You might get it so that it goes down. Let me see my drawing. There you go. And we look at that when we check the cardiogram. So once again, all that happens in the emergency room. You're short of breath, you walk in the emergency room, they're going to draw these labs, they're going to get an EKG, and they're going to get a chest x-ray. That determines the state of the heart and lungs, and are you in congestive heart failure, okay? So that's part of how we make the diagnosis, and usually, what's the symptom? The major symptom, shortness of breath, okay? A lot of stuff on that page. We'll come back to that. So we now understand the concept that the heart pumps out the blood to the lungs and to the aorta, so to the rest of the body. So let's put the whole body up there. Okay? And what occurs is, if the backup occurs, we get congestion. That's the word you want to take away, congestion. Once the congestion happens, the heart function declines. What does that mean? How do we know how the heart's working? Blood pressure. Put the cuff on, blow it up. When you blow it up, you stop the flow of blood coming to the, whatever you're checking. If it's the arm, you're stopping the flow of the artery. And then we listen with our stethoscope as we let the air out. And the first heart sound we hear, that's the top, called systolic. So that tells us the force of how the heart's pumping. You keep listening to the last sound, and that's when it starts to fill again, and you get the bottom number. Okay, so those two numbers tell us a lot about how the heart is functioning. So what we do is, when you get the decline, you can see a decrease in the blood pressure or an increase in the blood pressure. What does that mean? Remember, we talked about it. What if it's a valve? Or what if it's stenosis of the aorta? The heart has to pump harder to send the blood out. What does that mean? If it's pumping harder, your blood pressure's up. My whole point is that's how it is a diagnosis that takes all of these factors to be able to recognize, are you in congestive heart failure and what's the cause? So everybody understands these are the tools we use. We need to know if the heart's in a decline. You can have increased or decreased blood pressure. You can have changes in the heart in terms of its function. What does that mean? If your doctor has ever put his hand on your heart while you're being examined, what is he feeling for? He's feeling for what we call a thrill in the heart muscle itself. Generally, you can't feel it at all. So if we put our hand here, we're looking for what's called the point of maximal intensity to determine if the heart's enlarged. If we put our hand over the whole heart, we're trying to see, is the heart struggling? Because if the heart's struggling, if there's a bad valve, if there's a problem with stenosis, if there's a problem with insufficiency, you'll get movement of the heart muscle, and that's not normal. So we feel for that to try to make that determination. Once again, guys, this is all done in the emergency room. So if you've gone in with problems and they've done what I'm telling you about, they're assessing the function of the heart. Okay, so we now get to the point where Based on the physical exam, studies, and remember the big ones because we're going to go over this. Chest x-ray, EKG, BNP, and of course we get other labs, so I'll just put labs down here. And then remember with the physical examination, we're looking for a thrill over the heart. We're also listening to heart sounds, listening for a heart murmur, or sounds of stenosis, or what we call insufficiency. All of these can lead to congestive heart failure, okay? One of the big ones that I'm going to put here because it's very important. Board question. 19-year-old comes in with the heart attack. What happened with the 19-year-old? Cocaine. Does everybody follow me? So what we have to understand is there's many things that can cause trouble with the heart, okay? And what I'm showing you is some of the things we see when you come into the emergency room. What is the biggest factor that causes the problem with the heart that no one wants to talk about? It's still the number one cause of heart disease, especially ischemic. What does that mean? You have a blood vessel. Let me flip this, since you guys gave me enough pages today. You have a blood vessel. And what can the blood vessel do? Hope that concept worked. This is normal. This is dilated. And this is constricted. What does stress cause? Does everybody follow me? So if you're stressed out, your blood vessels constrict. What happens? It's like putting your finger on the hose. What happens to the blood pressure? It goes up. So everything's calm, there's no problem at all, life is going okay, and all of a sudden you're hit with a stressor, okay? That stress in and of itself is going to constrict that blood vessel. Now, does everybody that has stress in a constricted blood vessel have a heart attack? Of course not. But remember what we talked about. Any heart disease, whether it's the valve, whether it's something structural, whether it's high blood pressure, that stress event can cause a heart attack. And when you get your workup done, what does that mean? You go into the hospital, you're in the emergency room, they admit you and not observation because you told them to call Medicare. And while you're in there, they decide to do what's called a cardiac catheterization. What is that? What's interesting is when I started back in the 80s, they used to do the cardiac caths in your arm, okay? They would find the artery because it's real close to go from that artery into the heart. But what they found was they had to keep your arm out like this, and then the brachial plexus is under here, so people ended up with some neuromuscular problems related to that. And then because they're in there for a while, sometimes you get trouble with bleeding. And so the area that they're doing the catheterization, if you get bleeding in that area, led to a lot of problems. So then they went to the groin. So what they do is they get into the femoral artery and pass the wire up to the heart. And then when it gets to the heart, they squirt in dye. And what does that do? The left ventricle has what's called the left anterior descending artery. The right has the right artery, and the center is all taken care of by what's called the circumflex. Those are the main three. But off of that, there's branches. So you've heard of people having 5-vessel bypass, 2-vessel bypass, 1-vessel bypass. That's where it comes from. Reason I'm bringing all this up is what happens with stress. Not every time, But quite a few times they do the catheterization. What do they find? No disease. No disease, but you just had a heart attack and went into congestive heart failure. Why? Remember the stress, guys. It causes the constriction of that blood vessel. And if the stress is big time stress and you're very, very worked up about it, it can contribute to lack of flow to the heart muscle. I say contribute because there has to be something else. You can't be in perfect shape and have stress cause a problem. There's usually some underlying trouble such as blood pressure or lifestyle, too much salt, too much sugar, too much alcohol. Those kinds of things can contribute when the stress hits you that blood vessel constricts. It's going to cause enough problems to damage the heart muscle. Does everybody understand the concept? Because what happens nowadays, technology has advanced. I like this one. Anybody ever heard that expression? A non-STEMI. What does that mean? Non-ST elevated MI. What does that mean? Usually, remember we said the cardiogram? P wave, QRS, T. ST elevation. This is the ST segment. And when that usually goes up, it indicates a heart attack. This means you don't have it. How did we get to that part? Someone comes in with chest pain, someone comes in with atypical symptoms, and you order what's called a troponin. Anybody heard that term? It's a enzyme in the muscle of the heart, and it will get elevated before there's damage of the heart muscle, which is excellent, meaning we can prevent damage to the heart muscle now if you go early. So this is a commercial for if you know something's not right, get to the hospital or at least call the ambulance. I tell people that. Well, I don't want to bother anybody. That's their job. You call the ambulance, they come up here, they come in and see, and the first thing they do is going to get a cardiogram. And then they talk to the doctor at the emergency room. And that's what they do. And they like to, believe me. ENT, if you guys don't know an EMT, especially if you do, you know what I'm talking about. They like this stuff. They like to be called for an emergency situation on a person that's having a heart attack because their skills then get tested. If anybody watched the football game a couple nights ago, a couple Mondays ago, whenever it was, when that kid went down and he went out, and that trainer saved his life. Does everybody follow me? So they know what they're doing, guys. These guys are excellent. So you know your body. This is a commercial for get to the hospital or at least call 911 because they come zooming up. They get here, they throw the leads on you, they check your heart, and if they don't see any abnormality, but you still have symptoms they don't like, they're taking you over to the hospital. And then they do these tests, and guess what they find? If that troponin is elevated, that means you had an MI, but you didn't have any changes in your cardiogram. So we call it non-ST elevated myocardial infarction, because this shows there's been damage to the muscle fibers, but fortunately, minimal. And a lot of times with treatment, you have no problems whatsoever with the heart if it's caught early. So remember, guys, you know how you feel. Women, you're not as lucky as men. And we won't go through all those stories. All my daughters are home again. Bottom line is you don't get just regular chest pain. Women have different symptoms. Go figure, right? So what happens with a woman? Jaw pain is a common one. Got this pain in my jaw. I think it's a tooth. But it stays there. That's not normal. Does everybody follow what I'm telling you? If it's not normal, if you don't normally feel this way and all of a sudden you feel that way, at least call your doctor. I'm telling you to call 911 because if they come up, check you out, and so everything's fine, they go home, no harm, no foul. But at least get a hold of your doctor. You know what, doc, I have this pain in my jaw or behind the ear. I've had people say behind their eye they feel something back there that they can't rub out. Or they get a cough, and when they cough, they get a heaviness in the chest. Remember, Everybody's symptoms aren't exactly the same, but everybody's symptoms are different than normal. Please understand that. You know how you normally feel. If you are not feeling your normal self, you have to let your doctor know. If you get heaviness, what's heaviness? I've had people say, feel like an elephant sitting on my chest, okay? I've had other people say, I just feel like something's there. For me, when I used to work in the emergency room, it was called the hand sign. If a patient uses their hand and puts it anywhere on their chest, it's their heart till proven otherwise. So if you're doing this and saying something doesn't feel right, call your doctor. And if you get shortness of breath that comes on you quickly and you just can't get your breath, you call 911. And the reason I'm pushing all this stuff, guys, is the earlier you get to the problem of the heart, the better the outcome will be for you. Because we're going to go through the stuff that happens with the congestive heart failure and how quality of life changes and how mortality is affected. Does everybody understand what we've talked about so far? Because it's real important to understand it. All right, guys. So now, what goes on? Now we have the patient, and they come into the emergency room, and we identify that their BMP was elevated, their EKG showed that their left ventricle was enlarged, and the doctor says that you have type A or New York classification 1 heart failure. What does that mean? Remember, guys, everything is statistics. So statistics are kept. They know how many people had coronary artery disease last year, and they know how many of them had a heart attack because of it. And that's global. That's not just America. So what happens is the statistical analysis that has been done, all that data then is reviewed, and based upon how you present and how you respond to treatment is how we classify things. So we classify class 1 or class A, no symptoms. No symptoms. Medical problems. Medical problems. And the one I'm going to talk about most today is hypertension and diabetes. Why? Both have a unique characteristic. Silent killers. Did you hear that second word? Killers. It'll take you out. Both of them can. Diabetes, why? Because you don't feel it. You don't feel diabetes. And when you're a diabetic, you don't feel the classic chest pain, jaw pain, heaviness in your chest. Your symptoms could be so variable with the diabetes because it affects the nerves. Same with hypertension. Some people know they get a headache. Some people get blurred vision. Some people get their heart racing. But both of these can be silent killers. But remember what we said. You go into the hospital, they checked you out, they call you class 1 heart failure or class A heart failure. No symptoms, only medical problems. How do we treat? Lifestyle changes. What does that mean? Smoking, alcohol, drugs, lack of exercise. And the big thing is BMI and waist circumference. And no, I don't have a heart attack. Don't ever bring that up yet. I lost a couple for the wedding, but I gained it back. I got back on pasta. But the point is, what's normal? Should we smoke at all? No. Do a lot of people smoke? Yes. What happens? It becomes a habit. Why? Nicotine. Nicotine's addictive. So it gets in your system, you feel wonderful, you get that little jolt, and then as it starts to get out of your system, you crave another one. And the next thing you know, you're smoking a pack of cigarettes a day. And please don't vape. Please pass along. Vaping has metal inside of it. Everybody understand me? For it to work, they put metallic compounds in it. Metal isn't good for the lungs at all. They have found cancer in children because of this. So no vaping. Get off the cigarettes. You know what's good? Hypnotism. It's something to look into. So if you know someone trying to quit, get him to Dr. Stiles. I have to tell you that story. When Eastern Star, you guys all know where Eastern Star was? When I used to work at Eastern Star, Kathy Langdon was the director of nursing, and we had a picnic for Christmas. And she had Dr. Stiles come up. I don't remember. Some people took pictures, and I was on my hands and knees, but they claim he hypnotized me, and I was barking like a dog. So it works, guys. I was hypnotized. So it definitely does work, and they can help you with panic disorder. They can help you lose weight, and they can help you quit smoking. So I believe in it, okay? Alcohol. How many drinks are men allowed to have a week? Same thing. Why does women get less than men? I don't understand it, okay? They'll say 7, and they'll say for women 5. And again, it's an ounce of liquor, it's 12 ounces of beer, it's 6 ounces of wine. Does everybody follow the concept? And again, that is, if you read some of the literature from the Mediterranean diets and some of these things, they claim that a little bit of wine is good. Remember, guys, a little bit, okay? The problem we run into is what happens when you drink too much. Everything gets metabolized in the liver. So if you're drinking alcohol and the metabolism in the liver is going on, the medications that you're taking may not be as effective. So remember, 7 for a man, 5 for a woman per week is all you're allowed. Drugs. What drugs are we talking about? Any kind of pain medicine, so opiates, benzos, especially those mixed together. Stimulants. The one that they found to be a problem in children, Adderall. I'm spelling it wrong. And then ephedrine. And then I'll put amphetamines for weight loss. Okay? They may be good for the weight loss, but remember what they do. They're a stimulant. So now your body's in a stimulated state. What happens if you get stressed and you're in a stimulated state? That blood vessel shuts down. Does everybody follow me? So please pay attention to it. Lack of exercise. And no, it's not me. What happens when we exercise? We'll show the heart and the blood vessel. Okay? And then we'll put the arm. And we'll show the blood vessel coming down to the arm. When you exercise, the blood will put transport and, let's say, function. The blood vessel and the muscle are in shape. What does that mean? Think of a freshly cut piece of meat, fascia over the top of it. Everybody's seen that, right? The white fascia. The fascia covers the blood, or the whatever the muscle is. The blood comes through, the blood goes over the whole muscle, and the fascia keeps it from spilling out, okay? If you're in shape, the blood comes over the muscle, and it goes away. And I've watched it in the lab. I mean, it literally goes away. It's as if there's a drain on the muscle. So the muscle, blood comes over, and it's gone. That's when you're in shape. So what happens? Heart pumps, no resistance because you're in shape. What happens if you're not in shape? You can see the blood sit there. It's like you didn't empty the bathtub. I mean, the water's still sitting there. What does that mean? It's not in shape, so the blood does not go through the muscle as fast, so it's more work on the heart. Does everybody understand the concept? You don't want the heart to have to work harder. An out-of-shape muscle, it's out of shape, and it has to work harder. Let me bring that one back. So what we have now, BMI in waist circumference tells you you're out of shape. So it's just another factor to look. But the key understanding is the blood flows in a normal-sized blood vessel. It hits we'll draw like a muscle like this. It hits the muscle that's in shape. The blood goes over the muscle, exchanges oxygen, carbon dioxide, and everything moves forward. When it's out of shape, it backs up. That is, again, more work for the heart, and we don't want the heart to work hard. Okay? Everybody understands this is how we make a determination of the stages. So we talked A in stage 1. What is B in stage 2? This is now where you have risk factors. Same thing, risk factors. And now with physical exertion, you get short of breath, and it takes time of relaxation to get the breath back. Everybody understands the concept? Flight of steps. If you can go up a flight of steps without any problem, you get to the top and you're fine, you're stage 1 or A. If you go up that top of the steps and you get to the top and it's like, okay, now I'm ready. Does everybody understand that concept? That's 2 or B. So what happens is that's exertion. That's pretty good exertion. A set of steps, 14, 16 steps that you're walking up, using your muscles, using your legs. You get up to the top. Now you get a little short of breath. That tells you that you're in class 2 or class B. What do we do? And again, guys, you'll see at the end what to do. Remember, we'll put QOL, quality of life, and mortality. You have to pay attention to this so you know. A lot of people will say, something I ate. That's a big one I get. Well, what happened when you had that shortness of breath? I just ate. I think it was something that I ate. So we all blow it off. You know, we're all invincible. There's nothing wrong with us. Any of these symptoms we can get through. I'm bringing these all up so you catch them as early as you possibly can to make sure we get information to be certain that it's something you ate. Because if, on the other hand, it's the early sign of congestive heart failure, what do? EKG, chest x-ray, labs, exercise stress test. This is a big one. If anybody here has not had one, what it is it's a 12-minute test that we do on a treadmill. It starts out flat, and you can walk like I'm walking. Well, then what happens? They elevate what you're sitting or walking on, so now you're going uphill. Still walking, but now that you're going uphill, it's stressing the heart, so the heart has to go faster. Okay, everybody understand the concept? They put the leads on you, so we're watching the heart while you exercise. Exercise stress test. What do we do this for? To see, can the heart take what you're dishing out? You're saying that you're getting short of breath when you go up to the top of the steps. We want to watch you get short of breath with the cardiogram on you. Does everybody understand the concept? When I get a patient that has any symptoms in stage 2, you look at the risk factors, you see what you can modify, and then this has to be done. What is stage 3 and C? Now it's less exertion, brings on the shorter breath. What does that mean? That means now you can't get all the way up the flight of steps. So you're walking up the steps, and before you got to the top, and it was, okay, and you get your breath back. Now you don't make it to the top of the steps, you get short of breath. And you have to stop on the top of it before you get to the top. Or you'll get to the top and you have to sit down. You're so winded. Does everybody understand the concept? It's again showing us what the heart's capable of, and that's how they characterize this. And it all has to do with physical exertion and how you respond to it. So in stage C and stage 3, the exertion that you do brings on worsening of the shortness of breath. And along with 3, becomes palpitations. Everybody follow me? So now we know you're stressing the heart out because you get these palpitations. Can you get palpitations in 1 and 2? Yes, but it's not as common. When the palpitations come and you get evaluated, that's what they're going to find. And one of the things we do in the office, it's called a 6-minute walk test. That we pick out a place in the office, we put the pulse ox. I think I stole one today. Yeah. You put the pulse ox on the person's finger and you have them walk around. And you're looking for their heart rate to go up and their oxygen to go down. Does everybody understand that? So those are the things that we do to characterize and determine class C or 3. What is D and 4? Exertion not needed for shortness of breath. You can actually have shortness of breath at rest, meaning you wake up in the morning, you're short of breath. You get up out of bed, you're short of breath. You get up out of a chair, you're short of breath. So usually what we find is the patient obviously needs something for that shortness of breath, so we put oxygen on them. So you are now at stage 4 or D with oxygen all the time, and you will find yourself sometimes short of breath even at rest or minimal exertion. What's minimal exertion? Standing up. So if you're sitting on the edge of your bed with your oxygen on, you're feeling fine, you just get up out of bed and you're short of breath. Does everybody understand that concept? So now what we've gone through is understanding, I hope, how the heart muscle works, how you get the congestion, the A to D and the 1 to 4, how we characterize it. And a lot of times, as I tell you guys, it's for the doctors to communicate. You know, like when I call the emergency room, I say to them, I got a 75-year-old male with stage 4 congestive heart failure. He's O2 dependent and he's getting short of breath standing. That tells the story to the person that I'm talking to. Does everybody understand the concept? So a lot of why we do what we do is for everybody to communicate so they know the status of the patient we're dealing with. All right, so how does quality of life and mortality fit in? Let me give you some data. 50% of patients with class 1 to 3 have a 35% chance of living greater than 10 years. Okay? That doesn't sound too bad, right? We're going to go over to medicines. For you to do that, you may or may not be on oxygen, and you're on a handful of medicines. But does everybody understand statistically the concept that 50%, stage 1 to 3, 50% of the people in stage 1 to 3 have a 10-year survival with 35%. Does everybody understand that concept? Okay? So what happens? We'll take 1,000 people in that particular setting, and 500 of those that were followed, 35% of them lived over 10 years. Okay? Very important concept to understand. Stage 4. Once stage 4 is diagnosed, you have a 50% chance of living 18 months. Okay? Scary statistic. Remember what it is. It's a statistic, meaning data was collected, the statisticians put all that data out, and that's the number that they found. That 18 months from the time the doctor designated that you were in stage 4, there's a good chance that your end of life comes. Okay, and we're going to talk about all the things to prevent that from happening, but these are the statistics I wanted you to see. What about quality of life? Can you still drive in stage 4? I see everybody going like this. Yes, yes. It's amazing, guys. It has to do with our treatments that we have, and we'll go over that. Okay, it's called dobutamine. You have to get a line in so that there's access to the blood vessel, and you have to take dobutamine into the vein in order to keep that heart pumping as well as it needs to pump. Does everybody understand the concept? But we do have patients. Obviously, no one gets to go on a turnpike or a 4-lane highway, but they can go to the store, they can go to church, and I had a guy I saw last weekend that's still doing fine on it. But once again, that's pretty significant intervention for that to occur, but it's quality of life in a stage 4 patient that obviously has the desire to still do as much as they want to do, and technology has allowed us to. Does everybody understand the concept? All right. What I want to get to is the one that has changed the game. SGT2. Amazed when I read it. I was amazed at the effect that it had. This is the sodium glucose transport system in our body. What does that mean? Here's a cell. Here's the nucleus. This is called the cell wall. This is called the cytoplasm. And this is the nucleus. Everything happens in the cytoplasm, okay? And we have what's called the Golgi apparatus. All cellular activity happens in the cytoplasm. Does everybody follow me? How do you, and this cell wall, by the way, is 2 layers thick. How do you get in here? How does something from outside the cell get inside the cell? It has to be transported. So there's ways that it gets in, and it's usually carried by something. So what we've identified is for a cell to contract, it causes sodium and potassium are the battery of the body. So they go in and out of the cell in order to create that electrical activity. Because for those of us that don't know, we are electric, okay? Like there's a charge coming out of all of us. The EKG proves that. When you put those leads on your chest, there's charges from the heart that we measure. There's actual chemical activity in your brain that's electrically charged from the sodium and the potassium. So what happens is there's actually ways for glucose and sodium to get into the cell. So this particular drug, and I forgot to add the I, is it's an inhibitor. So what happens? It doesn't let the glucose back into the cell. So what happens? We pee it out. What happens? What goes with salt and sugar as it leaves your body? Water. Does everybody follow me? So by blocking this process, and again, this was started not for congestive heart failure. It was started for glucose control. So the drug was, I think they let it in 2012, okay? And these are called Glyliflovin. That's the category of these medications. There's been 4 of them approved. 1 in 2012, 1 in 13, 1 in 14, and 1 in 17. And what's amazing is we found that this particular drug improves quality of life and mortality. So something that was set out to control sugar, we found it decreases the BNP. Where does the BNP come from? Right atrium. It's called the sinoatrial node, and it goes to the AV node, and this is called the bundle of His. That's the electrical activity that occurs in the heart. The SA node sends out the signal. It goes to the AV node, then it goes down to the heart, and that's what causes the contraction and the relaxation. Does everybody understand the concept? The BNP is secreted in the atrium. 2 things about it. Congestive heart failure causes it to go up, but so does COPD. Why? Because the right atrium enlarges in COPD. So sometimes it's not an accurate science if you have both. But what we identified was decrease in the BNP and better quality of life. And it's amazing because the drug causes some potential problems in just diabetes alone. If you just have diabetes and you're taking it, all that sugar going through your urine, especially in women, can lead to urinary tract infections, okay? But once again, what happens is a lot of diabetics also have congestive heart failure. And all of a sudden they were finding that the patients were doing better quality of life. And as they were analyzing them, they found that 18 months went to 2 years. They found that the mortality rates had changed, and it was all because the glucose has a negative effect on the blood vessels of the heart. So elevated blood sugars in an uncontrolled diabetic, I've heard the surgeons say that they went in to operate and the blood vessel literally disintegrated in their hands. Does everybody follow me? So elevated sugar is not a good thing. This medicine was used to clear the sugar because usually the kidneys reabsorb all the sugar. This medicine allows that sugar to go through the kidney out into the urine. With it goes water, so that was helping the congestive heart failure. And potentially, from this particular nuance that they found, they're obviously working on some new stuff. So what I always tell my patients is, yeah, I'm going to give you some doom and gloom information when I tell you the statistics, but technology's advancing and things are coming out. And this is definitely one for the congestive heart failure patients to look at, that this can improve quality of life. What does that mean? That stage 4 person that's standing up and was getting short of breath, I got one. He's doing better. Now, is he running around? No. But you feel better. You're not short of breath all the time. That's what the quality of life is all about. You know, to just live is one thing. To live with quality is another thing. So what we end up with is we get to the point where every stage needs to be identified, and every stage needs a treatment plan. And everybody's different. Lifestyle change, number 1. Number 2 is an interesting one, sleep. REM sleep. If you haven't had a sleep study and you have congestive heart failure, get a sleep study, because they're doing a lot with the sleep and the REM sleep especially for improving quality of life, okay? So lifestyle changes, sleep, diet, of course, goes along with the lifestyle changes. And this is the one that people don't pay attention to. Exercise. Why exercise? What did we talk about? That muscle that's out of shape is stress on the heart. So if anybody's had a heart attack, or if anybody here knows if someone had a heart attack, you know when they get discharged, they're discharged to cardiac rehab. What's cardiac rehab? It's monitored physical therapy. What does that mean? They put leads on your chest, they put a pulse ox on your finger, and you exercise. And they monitor that. And they're looking at improving the condition of your muscles so your heart doesn't have to work as hard. Does everybody understand that concept? Okay. Last thing, and I'll let you go. Medications. Obviously, it has to deal with kidneys. Because if you guys heard me talk about kidneys, what do the kidneys do? Everything. Does everybody understand that? The kidneys regulate the blood in your body. The kidneys regulate your blood pressure in your body. The kidneys regulate your body's immune system. And it does it through a series of enzymes. One of them is called angiotensin converting enzyme, okay? ACE. So especially if you're a diabetic with any heart disease, they'll put you on an ACE inhibitor. But they have ACE inhibitor, ARBs, all these things are related to the fact that if you get angiotensin produced from your kidney and it's unregulated or restricted, it causes your blood pressure to go up. So everybody understands why we inhibit that, okay? Another thing that you may get is called a beta blocker. Nowadays, Coreg, metoprolol are the common ones. What does that do? Keeps the blood pressure down and stops the heart from working too hard. Okay, so you won't get the real fast heart rate on a beta blocker and your pressure won't be as high. Does everybody understand that concept? Quality of life, guys. These are things that help quality of life. Aldosterone, another chemical, has to do with the renin, angiotensin system. And the aldosterone blockers are medications that we use. And these medications, they're not commonly used unless you're in stage 3 or stage 4 of your heart disease. But the blockers of the aldosterone we use as well. And then, depending upon your disease state, we use vasodilators. Vasodilators. Nitrates. Some are worn on a patch, so they'll put a patch on it. What does that do? That dilates the blood vessel, because remember we talked about when that blood vessel constricts, that's when trouble occurs. So everybody understand the concept. So when you see your doctor, and generally I can treat it, but I send the patient to the cardiologist because at some point in time they're going to need a cardiologist, so the better to get to know the cardiologist sooner than later. So I recommend, even if I have a patient A or stage 1, that we've just identified risk factors and overall they're asymptomatic, I still get them out to a cardiologist because the cardiologists better manage heart disease than I do. And nowadays, especially with the new technology that's out there, you want to be state-of-the-art. It's very, very important to be state-of-the-art. So once again, guys, the medications that your doctor puts you on, you must be compliant. That's one of the biggest reasons we see problems. Compliance. What does that mean? That means if you're supposed to take 2 Lasix pills a day, you take 2 Lasix pills a day. What do I hear from my patients? Well, I was going to a birthday party and I didn't want to pee, so I didn't take the second one. Okay? Or, man, my legs were swollen. I took 3 of them today. You can't do that, okay? And that's what we call compliance. Follow what your doctor tells you, please. It's so important. Okay, guys? Now, what I leave you with is palliative care, hospice care. Does this mean death? Not at all. I'm a medical director of a hospice and palliative care group. I don't say the name because I don't promote what I do. Why did I get involved? When they first asked me 20 years ago, I said I'm not interested. Because to me, I thought, as a doctor, that this is like we're giving up, they're just going to die. But then I found out different. You know, the whole objective is to keep the person as active and healthy as they possibly can. And I've told many patients, I've had many patients that we throw out of hospice. Why? Because they lived for 3 years. You follow me? It's not a death sentence, guys. These are people that are well-versed in death and dying, and they know signs of change and decline. And that's who you want on your team. So if you get to stage 4 of congestive heart failure, that you're on the oxygen and getting up, you're getting short of breath, I'd recommend getting a palliative care consult to have the people that have seen 1,000 of you be involved in your case to help manage things that they go well. In terms of the hospice, what happens with the hospice is we see declining situations arising. What does that mean? You're sleeping longer, you're not eating as much, you're not thinking as well as you used to, you have lack of interest in different things. Could that be depression? Maybe. But once again, they're the experts. This is what they do every day. And again, God forbid it is the end of life and your mortality is coming. It's better to have someone with you that has that experience than to not have that person around, because they're very aware of end-of-life changes, and they can pick them up faster than anybody else, and they can help you with that process. But please, it's time to die, we're putting you with palliative care or hospice. In fact, palliative care, we use, someone goes in, they have congestive heart failure, but they break the hip, we have to fix the hip. That's when we use palliative care. because we want those people to get as well as they can, as fast as they can to get back to the quality of life they have. Everybody understand that? Again, guys, we went through a lot of information, and I spent the least amount of time on the sodium glucose transport, which was the major turn that made me think about this to talk to you guys about it. But what I found was a lot of my patients don't understand what congestive heart failure is. And a lot of my patients think that, like, once you have congestive heart failure, you have it forever and you're going to die. And that's not the case either. If it's stage 1 or stage 2, it's still reversible. You know, you just have to change. And change sometimes is very difficult to do. Once you get into stage 3, we usually can't reverse it, but there's treatments that are out there, and technology has advanced, so there's more treatments coming. And just so you know, what happens when you get into, like, the stage 3 going into stage 4. I just had a good friend of mine, a fraternity brother, young like me, that just had what's called an LVAD. That wasn't that funny. I am young. I'm teasing, guys. He just had what's called an LVAD. That's a left ventricular assisted device put in his heart. What that means is his heart wasn't pumping well enough on its own. So if he doesn't get that LVAD, he's going to die. And that's exactly what I told him when we sat in my office about 6 weeks ago. I don't want that. You're going to die. You want to check out? You know, of course not. So he had it done. He's doing fine. The guy that I had that we put him on the dobutamine, same thing. It's like, Doc, I want to see my granddaughter get born. I want to do these things. I still love going to church. I still love these different things. And I said, well, let's see. Your cardiologist may put you on an inotrope, and it's okay with me if we want to try it. He drove to my office. It was cool. You know, he came in holding his little IV pole. You know, it was still running. But the point is, guys, it's not an automatic death sentence. Quality of life comes from your determination to fight what you're dealing with. And then ultimately, please be compliant with the treatment they put together. And what's the biggest problem? I found it with my father. My father took 5 medications to control his blood pressure after his open heart. So I had the keys to his house, and I would go sneak in to see him. And he was like, no lights on in the house at all. I walked in, I thought he was in bed, and I heard the television. So I go walking into the family room. The television was on, and one 40-watt light bulb on one of those things that you have all those lights you can turn on. And there he is, throwing down peanuts with one hand and hard pretzels with the other. And I was like, what the hell are you doing? He said, watching TV. I said, don't you know there's salt in there? And he shows me the jar. Low salt, that's what it says. And I said, no, it's still salt. We stopped all that stuff. He never went back into congestive heart failure. So everybody follow me. These are the kind of things you have to pay attention to when you get into a condition that is that tipsy, as I call it. You know, my grandfather did it once by eating olives. You know, he was pulling down a handful of olives. It's like, what are you doing? That's all salt. Doesn't taste salty. You know, so again, you have to make sure you follow what the doctor lays out for your treatment plan. Please. Does everybody understand it? Hope I didn't get over everybody's head. It was a lot of fun going through it for me when I read this stuff, and that's why I wanted everybody to know there's things that can be done. And you improve the quality of life, and you improve your mortality by listening to what your doctor tells you to do, and especially please be compliant, even if you hate it. I got patients that hate taking statins. We didn't talk about the statins. That keeps the plaque away from the blood vessel, gets your LDL down. I have people say, I have aches and pains, I have this, I have that. Well, if you're in congestive heart failure, put your big boy pants on because you got to get those down. You have to take the statin. You have to. Does everybody follow me? Like there's sometimes I'm very easy with the patients. If we're doing it and we're just trying to keep things better than they were, then you modify the diet, we give you a chance. But if you're in congestive heart failure and your doctor's going to tell you no salt, limit how much fluid that you're taking in, and you got to get your LDL down, you got to take the statin, you got to take the statin. Is everybody with me? Good. Any questions, I'll answer for you. Oh, my word. I must have put you guys to sleep. Yes, ma'am. Oh, wait, you first, you're in the front. Yes?
Hold on.
Oh, if we get to, they get to, ooh, look at that. We get to talk in a mic.
I can remember when I was going through the stress and we're trying to figure out why I was passing out. and you said that, and you couldn't figure out why, but we finally decided it was stress. Is that?
Same concept. That stress causes that blood vessel to clamp down. Yep.
And then I passed out.
Sure. Once the flow, it doesn't matter. We're talking about the heart today, but the brain has the same thing, same 3 blood vessels that go to the brain. And that's what it's from. That's the cause. That's stress.
So I haven't had any seizures since.
It's good. That's good. So you've lessened your stress. Good. Another patient that listens. Awesome. It's good.
Anyone else?
Good. Other question, hon.
Wait.
Look at her running. That's good. We never had that. We're moving up, guys. 2023.
Hold
Look
it close.
out.
Hold it close.
What's a TIA?
Transient ischemic attack. What that means is that transient, short period of time, the blood doesn't make its way to the brain, and you can have stroke-like symptoms. What does that mean? Slurred speech, can't move your hand, your eyes don't work as well, you don't walk as well, but it clears up within 24 hours. Okay? That's what a TIA is. And it's a warning. That's a pre-stroke warning. So you have to do the complete workup. Scan of the brain, take a look at the blood vessels, echocardiogram to watch the blood going out of your heart. But it's usually very treatable and preventable for the stroke as long as you seek help when you get it, or whoever had it. Good. Other questions, guys? Thanks for having me. I don't think I was too late today either.